we go ahead and get started? So, Waleed, I'm going to let you introduce yourself. I'm not going to say your last name because I'll mispronounce it, and let you introduce yourself, when you joined our faculty here and what your interests are, and then go ahead with this presentation. Thank you very much for accepting our invitation and being a speaker this morning.
Thank you, Dr. Altman, for the invitation. It's an honor to be here to present to all of you. So my name is Waleed Abuzeid. I'm an associate professor in the Department of Otolaryngology, and I focus on sinus and skull-base surgery. I joined UW in May of this year. Prior to that, had spent 5.5 years on faculty at the Albert Einstein College of Medicine in New York. Spent my years training in a variety of different institutions, postdoctoral research fellowship at Penn, residency at Michigan, and then fellowship in sinus and skull-base surgery at Stanford before starting my career, as I said, in New York. So the goal today is to talk to you about a topic that is near and dear to my heart, aspirin-exacerbated respiratory disease, but with a bit of a twist or spin on it. The intention being to view this disease process from an otolaryngologic perspective. I have no financial disclosures. So the objectives of the talk are to define AERD and its underlying epidemiology, as well as to discuss the pathophysiology insofar as we understand it. Of course, our understanding of the pathophysiology in this particular disease process is incomplete. I'd also like to discuss the diagnosis of disease, a process that, of course, is critical and involves allergy and immunology. The management of disease from both a medical and surgical standpoint, again, with a focus on the sinonasal aspects of disease. And then lastly, we'll touch upon future directions, not only in the diagnosis of AERD, but also in its future treatment. So chronic sinusitis is an inflammatory condition of the respiratory epithelium in the sinonasal cavity that's been present for at least 3 months or longer. The diagnosis involves a combination of cardinal symptoms, which we'll discuss, as well as objective evidence of inflammation. And that objective evidence can be derived from nasal endoscopy, as you can see in this picture here, demonstrating nasal polyps and eosinophilic mucin, or from CT imaging, demonstrating mucoperiosteal thickening within the sinuses. Classically, we've categorized chronic sinusitis by phenotype into 2 fairly rudimentary categories, those with nasal polyps and those without nasal polyps. And then we had a whole bunch of these unclassified subtypes listed below here: allergic fungal rhinosinusitis, cystic fibrosis associated rhinosinusitis, and of course AERD, which is the focus of this particular talk. I think it's important to note that rhinologists in many academic centers, nationally and internationally, are making an effort to move away from this phenotypic classification to an endotype classification that's based more on the underlying immunologic abnormality in that particular cause of chronic rhinosinusitis. CRS is really kind of a catch-all umbrella term. There's multiple ways of getting there through many different immunologic pathways. Using a combination of tissue biopsies in the office or in the operating room, as well as serum studies, one can determine what the predominant immunologic or inflammatory response is. For example, is it a type 2 T helper 2 mediated response? Is it Th17 mediated response? Is it neutrophilic? And all of these different endotypes are at the moment still being characterized, but likely will be a part of our diagnostic modality going forward. So AERD, what is it? Well, it's the triad of chronic rhinosinusitis with nasal polyposis, bronchial asthma, and an underlying hypersensitivity to aspirin, as well as nonsteroidal anti-inflammatories. It affects about 1% of the general population. The prevalence is greatly increased in particular groups, specifically those with asthma, and even more so in those with asthma and underlying nasal polyps. In a meta-analysis of 27 clinical trials that involved adult asthmatics, again, it was the severe asthmatics and those asthmatics with nasal polyposis who were most likely to harbor an underlying diagnosis of AERD. There is a gender bias that's skewed towards females in a nearly 2-to-1 ratio. And in females, there seems to be more severe disease progression and more severe disease symptomology as well. Typically, there's no hereditary aspect. And the age of symptom onset is in the 3rd or 4th decade, although there can be earlier symptom onset in patients. And I've certainly seen patients in teenage years presenting with all of the manifestations of AERD and a positive aspirin challenge. Typically, diagnosis will lag behind symptom onset, average of around 10 years or so. But it is not uncommon for patients like this one shown here to walk into the clinic having had decades of symptoms, characteristic mouth open, chronic mouth breathing due to the chronic bilateral nasal obstruction, and here splaying of the nasal bone secondary to severe nasal polyposis, which of course affects facial morphology. The pathophysiology of disease, as I mentioned earlier, is incompletely understood, but a large component of it seems to be related to the arachidonic acid pathway. And as you all recall, arachidonic acid is metabolized through a variety of enzymes, cyclooxygenase enzymes, COX-1 and COX-2, as well as 5-lipoxygenase. 5-lipoxygenase in particular generates the cysteine leukotrienes shown here, which are aggressively pro-inflammatory molecules. Importantly, cyclooxygenase generates a variety of prostaglandins, some of which are pro and some of which are anti-inflammatory. And the one that I'd like to highlight due to its role in AERD is PGE2. PGE2 acts as a physiologic brake on 5-lipoxygenase, resulting in reduction in those pro-inflammatory cysteine leukotrienes that we just talked about. PGE2 is also coupled to the cyclooxygenase 2 enzyme. And it's important to note that in AERD2, there seems to be an inherent depletion of cyclooxygenase 2. Consequently, AERD patients have less production of PGE2, and that physiologic brake is released on 5-lipoxygenase, allowing for significant generation of the cysteine leukotrienes. And that results, of course, in the resulting inflammation throughout the upper airways. It's important to note that in AERD patients, because of that underlying COX-2 deficiency, the administration of any COX-1 inhibiting drug, be that aspirin or NSAIDs, results in essentially complete abrogation of PGE2 production, and you get a surge in the cysteine leukotrienes, which mediates the reaction that these patients will see when they take those particular drugs. As I mentioned, the cysteine leukotrienes, LTC4, D4, and E4 are highly pro-inflammatory and activate downstream effector cells, the mast cells, innate lymphocyte cells, type 2, eosinophils, and also upregulates the downstream receptors throughout the airways, resulting in bronchoconstriction, mucus hypersecretion, increased vascular permeability. And this has been demonstrated in a variety of studies. This fairly old study by now, a case control study of 140 asthmatics, around half of whom had AERD. It was evident that, again, if you look at the graph, the AIA group, which is the aspirin intolerant to asthma, i.e. the AERD group, relative to the aspirin tolerant asthma group, had significantly higher levels of urinary leukotriene E4. Furthermore, that was associated with severe asthma, with polyposis, as you can see here, where again, the AIA group with nasal polyps, i.e. the AERD subcohort, had the highest level of urinary leukotrienes relative to all of the other cohorts of patients. Aspirin administration would bolster this urinary leukotriene E4 even further. And importantly, and we'll touch upon this in a little bit, sinus surgery seems to have a fairly significant effect on the reduction of that urinary leukotrienes, and that effect is more pronounced in the aspirin intolerant patients postoperatively relative to their aspirin tolerant compatriots. Given that the cysteine leukotrienes have a downstream effect on eosinophils, there's been significant focus over the last several decades on eosinophils, which were considered, and by many still are considered, the primary effector cell in AERD. High eosinophils are certainly detectable in the polyps from AERD patients relative to their aspirin tolerant nasal polyp patients. And eosinophil products, which are again are detectable in AERD polyps, drive cysteine leukotriene synthesis and upregulate receptor expression in kind of a positive feedback loop. But it is important to realize, and this is a relatively recent observation, that even chronic treatment with montelukast and other receptor antagonists, aferlocast, doesn't relieve the nasal or bronchial symptoms in aspirin-exacerbated respiratory disease any more so than it does in aspirin-tolerant patients. Furthermore, the group in Harvard has tried a variety of eosinophil depletion studies and showed that this does not actually produce a significant clinical benefit in patients with nasal polyposis, whether they have AERD or not, or are non-AERD patients, suggesting that eosinophils, though they may play a role, may not be the only effector cell involved in the pathophysiology of disease, that additional mechanisms may well be a part of this disease process. More recently, multiple investigators and different groups around the country have looked at mast cells as a potential key aspect of AERD disease pathophysiology. We know that the baseline level of mast cell activation is increased in patients with AERD, and this observation really came about after challenging these patients with aspirin, where there was a reduction seen in FEV1 despite antagonism of the cis-LT1 receptor with montelukast, with concurrent elevations in the levels of tryptase, which of course is a mast cell marker. The theory is that mast cells are kind of the middleman mediating signal transduction between those upstream cysteinyl leukotrienes, in particular LTE4, and downstream pro-inflammatory prostaglandins such as PGD2, which can mediate bronchoconstriction in the airways.
Waleed, can we go back a slide?
Sure.
This comment, eosinophil depletion does not produce clinical benefit. How does that square with the recent use of drugs like dupilumab and the probable data that's going to come with the anti-IL-5 drugs that they are beneficial in nasal polyposis?
Well, the effect of dupilumab is one that's still under discussion in terms of its overall mechanism. There's a thought that the antagonism of IL-13 as opposed to IL-4 in dupilumab is actually probably the more important effect. And IL-13, as you know, has multiple effects on multiple cell types, mast cells, eosinophils, ILC2, as well as on a variety of matrix metalloproteinases, which of course are involved in epithelial turnover and polyp generation. If you cast your mind back to some of the earlier biologics, mepolizumab and omalizumab, so Xolair and Nucala, the clinical benefit seen in AERD patients was quite sporadic in those patients. As a matter of fact, although some of the earlier trials demonstrated benefit, mepolizumab, anti-IL-5, would have been expected to show a pretty significant benefit in AERD patients if eosinophils were really the key player. And yet the clinical benefit that was seen with mepolizumab was actually fairly limited to a small subset of AERD patients.
So do you think that, I think they're studying benralizumab for this, you think that's going to fail?
I don't necessarily think it's going to fail. I don't think it's going to be as good as dupilumab though.
Okay.
It's not to say that eosinophils don't play a role. It's to say that there are likely other cells that also play a key role, and ignoring those cells may explain the disparity in responses with these different biologics that may not necessarily act on some of these other end effectors. So what are some of the other potential players? And this is relatively recent data with cells that have been characterized, but their exact role in AERD has not yet necessarily been explained thoroughly. So the innate lymphocyte cells type 2 are also activated by cysteinyl leukotrienes and do appear to localize to the upper airway epithelium in patients with AERD. They produce a variety of pro-inflammatory interleukins as part of a type 2 inflammatory response. And importantly, they're part of this kind of feed-forward mechanism where you have upstream cysteinyl leukotrienes resulting in activation of these ILC2 cells and the downstream propagation or production of IL-5 and IL-13 from a variety of effector cells, including ILC2 cells. And that production of IL-13 may underlay the potential benefit of dupilumab, which again, we'll touch upon later. The group in Harvard, led by Tanya Laidlaw, have looked at platelet adherent leukocytes. And the reason for this is that we know that the level of platelet adherent leukocytes is markedly increased in AERD. Platelets adhere to 5-lipoxygenase expressing cells, neutrophils, eosinophils, monocytes, and release fairly huge quantities of arachidonic acid relatively, and this drives the synthesis of cystinolleukotrienes. That group estimates that approximately 70% of cystinolleukotriene formation is from these platelet-adherent leukocytes. And in fact, have shown a direct correlation between the levels of urinary LTE4 in AERD patients and the level of platelet-adherent leukocytes. They're looking at various therapeutics that potentially block this interaction to determine whether or not there may be another therapeutic modality for the treatment of AERD. But those studies are in either phase 1 and 2 and have yet to be completely reported. In terms of diagnosis, we use the same diagnostic paradigm here as we use for chronic sinusitis. And there's both a European and American set of guidelines, and they're fairly similar. 4 different cardinal symptoms that we look at, of which you have to have 2 of 4. So nasal obstruction being the most common, mucopurulent nasal discharge either from the nostrils or postnasally down the back of the throat, facial pain or pressure, and a reduction in the sense of smell, which actually seems to be the symptom that correlates the most with the degree of polyp burden. In addition to that, as I mentioned earlier, you have to have objective findings, 1 of 2, either derived from nasal endoscopy, where you would see polyps, purulent drainage, or edema in a specific region called the middle meatus, or CT imaging as an alternative, demonstrating mucoperiosteal thickening within the sinuses. Often we'll have both of these objective findings and all 4 cardinal symptoms in our AERD cohort. It's important when evaluating a patient with potential AERD that any asthmatic episodes following aspirin and NSAID exposure are teased out of the history, as well as any coincident history of the cardinal symptoms that I just discussed. It's important to specifically ask about subsequent NSAID use after that first reaction. And the reason for that is it predicts potential response to the aspirin challenge. So in patients with asthma and nasal polyposis in whom you suspect AERD, those who have had a single NSAID reaction in the past have an 80% chance of a positive aspirin challenge, and that bumps up to 90% plus if they've had a history of 2 or more NSAID reactions in their history. Regardless, patients with asthma symptoms developing on intake of aspirin or NSAIDs, or those who have nasal polyposis and concurrent asthma require some degree of further workup. A schematic there on the right shows the typical symptom progression, though this is by no means hard and fast, where patients will start with some degree of rhinitis and nasal drainage. 2 years later, they'll just start to develop upper airway kind of bronchoconstrictive symptoms with asthma. And then the aspirin tolerance tends to occur several years into the disease process, and finally have the manifestation of nasal polyposis with anosmia and complete nasal obstruction. The diagnostic testing involves an aspirin challenge with which many of you are likely familiar. This is the gold standard. In the US, it's primarily administered orally. In Europe, there are a number of centers that do bronchial inhalation or nasal administration. Less common is IV administration. There are a variety of contraindications, some of which are listed here. The oral challenge protocol was actually developed in the early or in the mid-1980s in San Diego at the Scripps Institute. And essentially this involves holding the antihistamines to try and avoid or block false negatives. Predose patients with montelukast or other leukotriene modifying drugs to try and blunt any potential severe respiratory reactions, and to measure FEV1 not only at baseline, but at every hour throughout the course of the aspirin challenge. And typically, classically, this is a 2-day challenge where every few hours, the dose of aspirin is escalated until a response is observed. Typically, patients are observed overnight, and the escalation continues the following day. And as I'll discuss later, this aspirin challenge can be kind of seamlessly blended into an aspirin desensitization and subsequent therapy, with the patient being discharged on daily aspirin. The reactions that are being looked for can be nasoocular alone, so nasal pruritus, nasal drainage, ocular tearing, or a combination of those nasoocular symptoms with a decline in the FEV1, which is kind of the classic reaction. Some patients will have just the respiratory reaction alone with a decline in their FEV1, and rarely you'll have a severe reaction, a laryngospasm or a systemic anaphylactic-like reaction that needs to, of course, be treated. Accelerated protocols do exist, and in fact, when I was on faculty there in New York, my allergy immunology colleague, Ellen Agershow, was a big proponent of these accelerated protocols, where the dose escalation actually takes place over half a clinic session. Every hour, the dose is bumped up. And again, this aspirin challenge can be transitioned into a desensitization and long-term aspirin therapy. The safety of these accelerated protocols has been evaluated, and they do appear to be safe, and their popularity is rapidly increasing. You avoid an overnight stay, and you of course avoid the resource utilization involved with all the ancillary support required for the classic 2-day challenge. So diagnostic algorithm, the positive challenge essentially occurs with the development of upper respiratory symptoms or an observed decrease in FEV1, which would be diagnostic. If you're able to reach that final dose of 325 milligrams, then the likelihood of AERD is significantly less. So when do you time the aspirin challenge? And this is actually a study that we published, again, from my time in New York. It's a prospective observational study with nearly 30 AERD patients whom we challenged both before and about a month after endoscopic sinus surgery. And we found that endoscopic sinus surgery suppressed the reaction to aspirin challenge. All of these patients, by definition, had a positive challenge before endoscopic sinus surgery. But 43% had no detectable reaction after endoscopic sinus surgery. And the cohort that had no detectable reaction appeared to have a lower level of serum eosinophilia, a lower PGD2 to PGE2 ratio, and lower levels of urinary LTE4. The key take-home message from this study for us was to establish the AERD diagnosis with an aspirin challenge before subjecting the patient to surgery in those in whom you suspect disease. In those in whom you know you have disease, doing the aspirin desensitization after surgery may actually be safer. Moving on to the surgical management of AERD. So this starts with diagnostic imaging. Our gold standard is a non-contrast CT scan. We get high resolution imaging and reformat this into coronal and sagittal slices. It's important to get these high resolution scans because we use it as part of our intraoperative stereotactic guidance to keep us away from critical structures like the orbit or the skull base. Often these patients with AERD and their chronic inflammation and polyps will have some dissolution or dehiscence of critical bone, such as the lamina propria, the medial wall of the orbit, or the skull base, which at baseline is only 0.4 millimeters thick. And so it's important to have this, this ability to navigate during these fairly complex and involved surgeries without risking the eye or the brain. The CT also helps quantify the extent of disease. 90% or more of patients have complete opacification of all 8 paranasal sinuses or a significant degree of mucoperiosteal thickening. And that's illustrated here. You can see that triplanar reformats of a normal patient at the top. All 8 paranasal sinuses are well aerated. The sagittal there shows a nicely aerated frontal sinus, and then the axial shows a well aerated sphenoid sinus bilaterally, as well as the ethmoids. In AERD, you can see that all 8 sinuses are typically opacified, and this is not an uncommon picture to see the involvement of every paranasal sinus with complete opacification and no visible air. The goal of surgery is to reduce polyp burden, reestablish drainage and ventilation of the paranasal sinuses, allow us in the clinic scenario to surveil the sinuses for polyp recurrence, which if caught early can be treated with oral corticosteroids as opposed to taking the patient back to the operating room, and also to optimize the delivery of topical medications into the sinuses. And that last goal is probably the most critical, and I'll touch upon that in a moment. Here's a video of just a short video of an AERD patient undergoing revision surgery, actually. And so this is a tool called a microdebrider. It's a glorified roto-rooter, actually. It's actually won a number of engineering awards, so it's perhaps underplaying it a little bit. It's fairly technologically advanced, but it allows us to remove polyps while evacuating blood and debris at the same time. So this is the patient's right nasal cavity. We're removing the uncinate process here, which is extremely osteitic. That's fairly common in AERD, where the bone will in some places thicken up. Here's some polyps within the maxillary sinus, and again, we're using kind of an angled microdebrider to remove those polyps and reestablish access to that maxillary sinus. And you can see that AERD patients, these polyps can be fairly bloody. There can be a fairly significant amount of blood loss. And I just sped ahead here to the end of the case where you've got a wide open ethmoid cavity in front of you here. And you'll see that after I deploy this propel stent. Dead ahead is the sphenoid sinus opening. To the right there is the maxillary sinus. And then up top there is the frontal recess. That stent that I placed in there is something called a propel stent. It's a drug-eluting stent which releases mometasone into the surrounding mucosa. And there's good clinical trial, randomized clinical trial evidence indicating blockade of polyp formation in the postoperative period and better healing. In AERD, we often encounter this situation of the failed sinus, and this occurs far more commonly than in any other subtype of chronic sinusitis. As I mentioned earlier, the effectiveness of surgery really is predicated on the ability to deliver topical corticosteroids into those sinuses. Standard endoscopic sinus surgery, which is typically what you see from otolaryngologists who are kind of non-sinus specialists and from non-academic centers, involves making fairly limited openings into the sinuses. And that predisposes the sinuses to potential failure through a variety of modalities. That can be technical shortcomings. Maybe the opening just wasn't large enough, or critical pieces of bone, such as the uncinate process, were left in place. In the context of AERD, there's a significant amount of mucosal remodeling, and polyp recurrence can potentially occur, thereby blocking the sinus altogether. And also in AERD, we see this phenomenon of ciliary loss and dysfunction, resulting in stagnation of that mucociliary blanket. Normally, that mucus is pushed up and out of the sinuses. But if it stagnates, that is a fantastic growth media for bacteria and other pathogens to set up shop and, again, drive further inflammation and further blockage of those sinuses. We do know from multiple published studies that more aggressive surgery in the context of AERD can improve outcomes. And the sorts of things that we're talking about are essentially larger openings. So if you look at this coronal scan over here, the gap that you see between the bottom of the patient's left orbit and the top of their maxillary bone or inferior turbinate is the standard opening. That red line delineates the medial maxillary bone that we would remove in what's called an extended maxillary antrostomy or mega antrostomy, which is a very common procedure that I perform in AERD patients. You'll see this kind of accelerated video over here, where we're removing a portion of the inferior turbinate to allow us access to that medial maxillary bone, the bone in red. And then we use a variety of instruments, as you'll see here, to remove that bone. In this particular patient, there's actually been sequestration of fungal spores within that maxillary sinus, and that's a fungal mycetoma or fungal ball sequestered within the maxillary sinus. So we remove all of that maxillary bone, and you can see that the opening is now being extended down to the level of the nasal floor, and that converts this sinus to what's called a gravity-dependent system. So instead of requiring intact ciliary function to push mucus up and out of that standard opening, you now have a large enough opening that gravity alone, independent of ciliary function, will essentially pull mucus out of the sinus. And furthermore, you have a much bigger opening for irrigation and drugs to get into the sinus. We can do the same sort of thing in other sinuses. So the frontal sinus, which is actually the most common site of polyp recurrence and failure in AERD, is again typically or standardly approached through an antrostomy called a draft 2A that creates about a 5 to 6 millimeter opening. And you can see that here in this coronal in the patient's right frontal sinus. That gap is your typical standard frontal sinusotomy. Now, unfortunately, the type of opening, the size that you can achieve isn't really that great. And we know that if you have a less than 5 millimeter opening, a third of those patients are going to stenose that opening. It's going to close off and you're going to have an assured failure. We can do something called an endoscopic modified Lothrop procedure, which essentially joins the two frontal sinuses together across the midline, creating a single frontal unit. So compare this photo or this CT scan to this. We're removing the superior septum and drilling down the intersinus septum so that the left and right frontal sinuses are brought into continuity and drain through this large funnel-like opening. And again, kind of an accelerated video. The advantage of these large openings is that they're much less prone to closing off. And again, in an AERD patient, particularly those undergoing revision surgery, this will be one of our go-to maneuvers to try and maintain an opening up into the frontal sinus. This is using an angled endoscope. We're looking upwards into the frontal sinus, diamond drills to take down the bone, and then a variety of hand instruments combined with the drill to kind of increase that antero-posterior diameter and try to minimize the likelihood of this stenosing closed. And you're actually looking into the bilateral frontal sinus there. You have this wide open horseshoe-shaped opening, cribriform posteriorly, the anterior table at the top of the screen, and then again, a propel stent placed to stent things open while it heals. Surgical outcomes, well, we know that you can achieve significant improvements in quality of life scores, and that this is sustained for at least a year. The degree of improvement that we see is similar in AERD and aspirin tolerant patients for that initial period, but then tends to diverge, doing worse in the AERD patients than in aspirin tolerant patients. Now, if you combine that surgery with a fairly rapid institution of aspirin desensitization and long-term therapy within about 3 to 4 weeks of the surgery, you can sustain that improvement for greater than 30 months. We also see improvements in asthma control that are fairly rapid onset after the surgery. Better symptom scores, a decreased frequency of asthma attacks for 12 months postoperatively, far fewer inpatient, outpatient ER visits, and a reduced requirement for inhaled and systemic corticosteroids. Objectively, we see an improvement in validated CT scores as well as in validated nasal endoscopy scores. But it's important to keep in mind, of course, that AERD patients do retain this 10-fold higher risk of polyp recurrence after endoscopic sinus surgery relative to aspirin tolerant patients. And then in those who defer aspirin therapy, they're essentially going to recur at some point. And that recurrence is going to require a revision surgery. And so the importance of instituting aspirin therapy, or now in the more recent era, I guess, the use of immunomodulating biologics is of absolute paramount importance. Cannot rely on the surgery alone for sustained long-term benefit. Surgery can also optimize your aspirin treatment response, and this was a follow-on study by our group in New York. This time, 40 AERD patients, which were enrolled prospectively before endoscopic sinus surgery, all of whom underwent pre-operative aspirin challenge and desensitization. Variety of outcomes, both asthma-related as well as rhinology-related. Patients were stratified into a non-responder group and a responder group based on their response to that aspirin challenge. We did find, interestingly, and this is a subject of continued investigation, that non-responders were more likely to be African-American and had higher levels of baseline IgE. 24 of the 40 patients recruited into the study subsequently required endoscopic sinus surgery. And after that endoscopic sinus surgery, underwent a second aspirin desensitization. All 24 of those patients, despite 15 of the 24 being non-responders before surgery, were able to tolerate aspirin challenge and desensitization after surgery. The non-responders who previously, again, prior to surgery, saw a significant IgE increase after aspirin challenge, saw no increase in their IgE, or very limited increase in their IgE, which was non-significant in their post-operative aspirin challenge. This suggests that antecedent endoscopic sinus surgery can enhance aspirin treatment responses in AERD patients. And interestingly, that ESS may convert patients who failed aspirin therapy before surgery to a more responsive phenotype after surgery. So you shouldn't necessarily give up on those folks who are unable to tolerate aspirin early on prior to their having undergone endoscopic sinus surgery, because perhaps after surgery, they will actually be able to tolerate the aspirin and be placed on aspirin long term. And finally, keeping in mind that that cohort with very high IgE tended to be the non-responders, endoscopic sinus surgery might be particularly useful in those patients in terms of converting their phenotype to one which will tolerate aspirin. The medical management of AERD is fairly wide in breadth. There are a variety of different modalities that we use. Topical sprays and irrigations were kind of the mainstay for a very long time, and specifically fluticasone and mometasone sprays, which are shown to improve quality of life scores, endoscopic scores, and reduced polyp size and the likelihood of polyp recurrence. But computational fluid dynamic studies show that actually those aerosol sprays have extremely poor penetration to the frontal and sphenoid sinuses, are essentially undetectable in the frontal sinus, and less than 5% of the drug volume is delivered into the sphenoid sinus. This can be improved somewhat by using a liquid vehicle, so using saline as the vehicle to deliver the steroid. And this is something that myself and many of you will often do in these patients, where we'll start them on these budesonide rinses. We know, again, from computational fluid dynamic studies that we can optimize that drug delivery into the sinuses. In particular, you can bolster in the postoperative patient delivery to the frontal sinus to about 30 to 40% of the overall drug load, and to the sphenoid sinus to about 20 to 30%. This decreases nasal polyposis and recurrence rate. It doesn't appear to have any effect on the HPA axis at all, and can be used long-term. There have been 2 clinical trials that have demonstrated long-term use over the course of 3 to 5 years. BID is safe. No change in intraocular pressures, and again, no change in serum cortisol that was clinically relevant. Topical antimicrobials are used by many an otolaryngologist, and yet there is absolutely no evidence supporting their use. And this includes the dissolving various antibiotics within the saline rinse and using the saline rinse to deliver that antibiotic or antifungal into the sinuses. Oral antibiotics, on the other hand, do have some evidence, though that evidence is limited to a select few drugs. So the utility of non-macrolide antibiotics is highly questionable. Many a sinus patient will be treated with Augmentin. There's actually very little evidence that Augmentin is beneficial in chronic rhinosinusitis alone, let alone AERD. But there is level 1 evidence to suggest that macrolides, specifically clarithromycin, administered over the course of 21 days, can reduce polyp burden postoperatively and improve quality of life scores. And this has subsequently been demonstrated in a couple of other antibiotics, doxycycline, as well as sulfamethoxazole trimethoprim, so Bactrim. And the effect of these antibiotics is actually likely mediated by their chemical structure, the anti-inflammatory effect that's inherent to that chemical structure, much more so than their ability to actually kill microbes. Keeping on the theme of anti-inflammatory medications, oral corticosteroids are part of the mainstay of treatment as well. This is my typical course. There are a variety of different courses. There's no hard and fast rule. There's very little evidence supporting one course over another. I do a 12-day taper starting at 30 milligrams. The duration of benefit is really only 2 to 3 months. Patients will often see a rapid short-term improvement. They'll love you for it. Their symptoms will get better very quickly for at least a short period of time, as will their endoscopic and radiologic appearance. But there is a significant side effect profile, and risk-benefit analyses have shown that if you take more than 2 steroid tapers in a year, the potential downside of systemic corticosteroids outweighs potential risks, for example, to the orbit, to the skull base, with surgery. And in those patients who've undergone more than 2 oral corticosteroid treatment courses, endoscopic sinus surgery should really be considered. And of course, the mainstay of treatment here, aspirin desensitization, a variety of contraindications, the goal, of course, being to optimize and maintain both asthma and sinonasal disease control. The exact mechanism of action is as yet unknown, but we do see an effect in terms of cysteinoleucotriene levels, which are suppressed, and a downregulation in their receptors on end effector cells. And there also appears to be a reduction in leukotriene synthesis mediated through a STAT6 pathway as well, which was more recently elucidated. So patients are pre-treated with montelukast, oral steroids if required, well before the actual desensitization therapy. They stop antihistamines 48 hours before treatment. Endoscopic sinus surgery, as we discussed, can potentially allow you to get through the desensitization course. An escalation protocol is instituted that's not dissimilar to that for aspirin challenge. Again, this is the accelerated protocol. Most reactions will tend to occur at around 45 to 100 milligrams. The escalation is continued until you run into a reaction, which are then managed accordingly. The endpoint's achieved after you have a positive reaction. You then repeat the provoking dose, and it's less likely that that second provoking dose is going to induce an actual reaction. And then you continue the escalation up to 325 milligrams, upon which the patient is discharged after an observation period. and continues to take 325 milligrams daily. Older desensitization therapy paradigms involved escalating up to 650 milligrams or even higher and discharge on 650 milligrams BID. The fact is there's actually no difference in efficacy between treating a patient with 325 milligrams daily or giving them extremely high doses, 650 milligrams BID. There's been a variety of randomized control trials. It's a busy slide. I'm not gonna belabor the point here, but there's strong evidence that aspirin desensitization improves olfaction, improves nasal airflow, reduces the likelihood of polyp recurrence, increases a variety of health-related quality of life measures, and also from a kind of immunologic standpoint, can alter some cytokines, but not necessarily all. So we don't necessarily see a decrease in some of these cytokines. Again, I won't necessarily harp on about the molecular pathways in which they're involved, but we would expect to see a reduction in some of these, particularly interferon gamma, but we do not. Dietary salicylate avoidance is potentially adjunctive treatment for AERD. There's actually a fairly significant salicylate load in our regular diets. It's found in dried fruits, berries, herbs, alcoholic beverages as well. The average consumption is anywhere between 3 to 5 milligrams. A crossover study was conducted by Sommer and colleagues. It's a multi-center study. There were only 30 patients, but they were crossed over at 6 weeks from a regular diet to a low salicylate diet or vice versa. And the investigators looked at a variety of subjective outcomes listed below here, as well as objective outcomes as well, the endoscopic, validated endoscopic scores. And you can see here, take home message, when you compare the low salicylate diet to the regular diet, you've got a significant improvement in the low salicylate group with regards to their sinonasal symptoms as measured on the SNOT-22 questionnaire, the asthma control questionnaire, the nasal and sinus symptom scores, as well as objective measures, the Lund-Kennedy endoscopic score, as well as the POSE, which is another validated endoscopic measure of disease burden. Leukotriene modulation is something that's also been investigated, mainly due to the observed upregulation of the cis-LT1 receptor in AERD. A variety of leukotriene modifying drugs have been tried. As you know, that there's upstream inhibition of 5-lipoxygenase using drugs like Xylutin, or more downstream antagonism of the cis-LT1 receptor using montelukast or zafirlukast. The outcomes indicate that Xylutin can improve nasal symptoms, it decreases mast cell mediators following an aspirin challenge, and this is associated with a decrease in nasal symptoms and increased nasal airflow. However, of course, there is a side effect profile associated with Xylutin, particularly with regards to hepatic side effects and the need for hepatic monitoring. Montelukast, perhaps a better tolerated drug, more widely used, also improves symptoms, nasal airflow and inflammation, whether or not a patient is aspirin tolerant or aspirin intolerant, in fact. And this actually is an adjunctive treatment that we use in the vast majority of our AERD patients. So in summary, a trial of leukotriene modifying drugs should be considered for persistent symptoms of AERD. They have utility, as we mentioned, for pre-treatment before aspirin challenge and desensitization. There has been no head-to-head evaluation in the context of AERD between the different leukotriene modifying drugs, nor has there really been a look at combining upstream blockade of 5-lipoxygenase with downstream blockade of the actual receptor. And perhaps that's an area for future investigation. And lastly, the immunomodulating biologics. So dupilumab is a fully human monoclonal antibody. It inhibits both IL-4 and IL-13 signaling. It's been approved relatively recently in the last year and a half for chronic rhinosinusitis with nasal polyposis. It's been poorly controlled. And it's also been approved for severe type 2 asthma, the other indications there as far as dermatitis, atopic dermatitis and the like I haven't mentioned. There's been a fairly large multi-center international phase 3 randomized control trial that was published just last year in the Lancet. And this is a fantastic study for those of you that haven't actually looked at it. I'd encourage you to do so. There were two studies that were conducted, and actually the results were reported separately and also pooled. The inclusion criteria with adults with bilateral chronic rhinosinusitis with nasal polyposis who had ongoing symptoms despite use of intranasal or inhaled corticosteroids. And also despite use of an oral corticosteroid taper or endoscopic sinus surgery in the preceding 2 years. The shorter study was the Sinus 24 study. nearly 70 hospitals across 13 countries, nearly 300 patients randomized to either dupilumab, given on a bi-weekly basis, or every 2 weeks rather, over the course of 24 weeks versus placebo. And then the longer Sinus 52 study with 450 or so patients randomized to 3 different treatment arms, dupilumab every 2 weeks for 52 weeks, dupilumab every 2 weeks for 24 weeks, and then moving to a less aggressive regimen of every 4 weeks for the remaining 28 weeks, or placebo for the full year. The endpoints were nasal polyp scores, nasal congestion scores, and a variety of objective measures. So your Lund-Mackay, your University of Pennsylvania smell ID test, FEV1, and then some validated surveys, the SNOT-22 and the asthma control questionnaire. Important to note that about 30% of the pooled cohort had AERD, and they showed similar improvements in the outcomes to the aspirin tolerant majority. You can see here in the diagram, the dark purple line is the placebo group, the blue line is the treatment group. Then in the Sinus 24 study, there was a reduction in sinus polyp scores, although there was some regression of the polyps, or some recurrence, I should say, of the polyps after cessation of treatment. In the Sinus 52 study, again, there was a reduction in the polyp score, and that was sustained throughout the year-long treatment. Nasal congestion scores also improved. And again, you see this kind of return towards baseline in the shorter Sinus 24 study once the treatment was discontinued, and a sustained improvement in the longer year-long study. Interestingly enough, and I have no explanation for this, the complication rate was actually lower in the treatment arm versus the placebo arm. And those are complications like nasopharyngitis, asthma, epistaxis, headache, injection site erythema. Important also to note here that treatment seems to delay the use of oral corticosteroids or endoscopic sinus surgery. So this is a cumulative event rate on the y-axis and then time on the x-axis. Again, you can see the treatment arm. This is the pooled results from both studies in blue, and far fewer events, that is oral corticosteroid use or nasal polyp surgery in the treatment arm versus the placebo arm. And that's an important endpoint as well. So what are some future directions, just to end here? There's a variety of different release assays. The sulfatoleucotriene release assay is one that's been looked at. The results of such studies are not actually that promising. Aspirin challenge, we know, results in LTC4 release from peripheral blood leukocytes. The idea here is to measure the LTC4 and hope that you can, just using a quantitative assay, differentiate between patients who have AERD and those who are aspirin tolerant. But this isn't necessarily reproducible and has yet to be validated. Basophil activation test, again, predicated on the expression of these surface markers on basophils after aspirin challenge. Thus far, inconsistent results. The ASPI test is perhaps one of the more promising. Aspirin produces a 15-heat. That's one of the products of 5-lipoxygenase, and that accumulates in nasal polyps and peripheral blood leukocytes. If you select for patients who are highly likely to have AERD, it's actually a fairly good test. But in an unselected population, for example, all comers who show up to the clinic with nasal polyposis, the actual ability to discern AERD is actually not that great. Newer clinical therapies are kind of directed at this platelet leukocyte aggregate formation, which we talked about earlier. Prasugrel is a drug that blocks aggregate formation. This is currently, I believe, in a phase 2 clinical trial. There are a variety of thromboxane receptor antagonists being looked at. These, again, blockade that platelet interaction. Ifetroban, which is an oral thromboxane inhibitor, is in a phase 2 test, phase 2 clinical trial. CRTH2 antagonists are intended to blockade the type 2 inflammatory response. I have very limited data on what's going on with those clinical studies. It was kind of all the rage several years ago, but very little has been reported with regards to these CRTH2 antagonists. And then, of course, we kind of touched upon dietary modification, but there have been attempts more recently to encourage low omega-6 fatty acid diets, which is apparently supposed to reduce the production of the cysteinoleucotrienes. So in summary, AERD diagnosis should be suspected on history, confirmed through aspirin challenge. Optimal treatment involves fairly close collaboration between Allergy, Immunology, and ourselves. Gold standard treatment involves both medical and surgical treatment, and future treatments will directly modulate the involved immune pathways. Got a variety of references here. Here's the keyword for the day to get your CME credits. And just kind of a logistical thing, how do you refer a patient you potentially suspect? Well, you can click on referral to Odo, which is an epic order. This will come up. Select UWMC, and then two different sites will come up, either our Montlake campus here or the Eastside Clinic in Bellevue. Alternatively, and this should be on the copy of the slides that was sent to all of you, you can just contact our patient care coordinators directly if you've got a patient who lives on the east side. Kimberly Barth over here in Seattle, Karen Steele. And this is our team. I cover both clinic here and over in Bellevue. Ian Humphreys, who's a division lead, is based purely here at Montlake. And then our newest recruit, Arya Jafari, who just started a month and a half ago, having completed fellowship at Harvard, covers Montlake and the VA. And our cell phone numbers are there. Feel free to call, text any of us with any questions, email as well. You know, at your convenience, happy to curbside or provide more in-depth consultation info as you desire. Thank you.
Thank you very much. Are you guys doing the aspirin challenge and desensitization, or do you leave that to the allergy service?
We leave that entirely to you. And I know that it's currently not occurring, I think, due to some staffing issues and the like. But yes, I've always relied on my allergy immunology colleagues for that. And I think the vast majority of otolaryngologists and rhinologists would. I can't think of a single one who does aspirin challenges.
Yeah, Len, we just hired a new nurse, so hopefully we're going to have that program back up and running soon.
Fantastic, Drew.
Is this partially a problem of standing upright? Do the mammals that walk around on four extremities not have this problem?
Of AERD?
Or nasal polyposis?
Yeah, you know, that's an interesting question. I don't know whether or not, you know, animals that go around on all fours develop nasal polyps. I do know that primates, who I guess are not, you know, I guess they're considered upright, but they also spend a lot of time kind of in a more, you know, on all fours as well, can develop nasal polyps. But as far as other, you know, mammals and the like, I'm not actually sure whether or not nasal polyposis is a feature of sinus disease in those animals.
Well, the gorilla, Greg is online here, and Drew, they've had to work on the gorilla at the zoo, right? He had terrible disease, didn't he?
Yeah, he did. Hey, Waleed, great job. Really enjoyed it. Nice seeing some ENT physiology there. I'm impressed. I learned a lot. Yeah, Drew can talk about the allergies in the gorilla if we want to. Drew, I don't think you tested him for aspirin sensitivity, so -1.
No, yeah, we didn't challenge him. We should have. But
what were you thinking? You were thinking about those big fangs and not wanting.
Yeah, I was nervous enough.
Do you think the biologics may get good enough that your burden of surgery is going to significantly go down?
I'm almost certain that they will. You know, they're likely to put folks like Greg and I out of business as far as AERD is concerned. I think we're probably a ways off from developing biologics that are able to treat the variety of different endotypes in chronic sinusitis. For AERD, we're definitely seeing far better treatment responses with dupilumab than we were with earlier generation biologics. And I suspect that's going to continue to improve. As far as kind of chronic rhinosinusitis in the more general sense, you know, there are molecular therapies being developed for a variety of other endotypes. So Th17 blockade, for example, for patients who suffer from that particular endotype of chronic sinusitis. So, you know, in answer to your question, yes, I suspect they're going to get better and that patients are going to require surgery less and less going forward.
You had that picture of the mometasone-eluting stent and just alluded to the fact that they work. Do you put them in every time?
For the AERD cohort, I do, simply because the data indicates that polyp recurrence in those patients is far more likely than it is in any other subtype of chronic rhinosinusitis. So in those patients, I do try to put the drug-eluting stents not only into the ethmoid sinus, which is what you saw in the video, but there are smaller Propel stents that you can actually place to stent open the frontal sinuses as well and elute steroid in that area. So yes, I do use them essentially universally in AERD patients. And I'd say 50 to 70% of the time in patients with nasal polyposis who are aspirin tolerant.
We got a big audience out there. Anybody else with pressing questions? You can put those stents in at the time that you operate. Can you put them in repeatedly in the outpatient clinic if you see that polyps are regrowing?
This is an area that I know Greg's got a lot of expertise in, but there is a office-based stent, basically. So it's a slightly different design with the same purpose, but a longer release profile. So the ones that we place in the operating room release mometasone over the course of 30 days, with the majority of mometasone actually released in the first 10 days. The in-office version releases mometasone over the course of 3 months and is designed as such that you can actually place it into an operated cavity. So you need to still have had an endoscopic sinus surgery in the past. But for example, if a patient presents with AERD, having had surgery in the past and shows complete obstruction of their ethmoid cavity in the office, there's a ton of polyp regrowth, you can use this particular variant of the Propel stent and essentially just push it into the ethmoid sinus past the polyps. And over the course of that 3-month period, there's good data, again, from randomized controlled trials indicating that it will allow for dissolution of those polyps and improvement of sinonasal inflammation at the level of the epithelium. Greg, do you have anything to say about the in-office Propel?
That was a nice summary. You can certainly use Propel, the 1-month stent in the office, or Sinuva. The challenge is always just reimbursement. And these little stents are expensive. The Propel is about $800 each. The Sinuva, which is the 3-month version, is about $1,200 each. So getting the payers to pay for it is problematic. It's getting better with like United Health, Aetna, Blue Cross Blue Shield of Illinois. Those are all, they cover it. And in a lot of patients with bad polyps, it's a really nice way to control the disease long term. You just put it in, lasts for roughly 3 months, and then I see them back 3 months later, and then put another Sinuva in. And for patients who don't want to irrigate with budesonide, or if it's not working, or those who can't get Xhance covered, this is a nice option. But they, as Waleed said, they do have to have had a nice sinus surgery and a pretty straight nasal septum as well, because the little stent is 7 millimeters before it deploys and opens up. So it's a bit large to corkscrew into the nose in some patients.
Any other questions?
How are things in the Bronx?
I loved my time in the Bronx. It was pretty busy. I mean, there was you're talking 3.5 million patients who essentially came to one academic center. So their caseload was huge. And we had a very large cohort of AERD patients and a very engaged allergy immunology colleague, Elena Jershaw, who I continue to collaborate with, who actually spent half her time in the lab doing research on AERD as well. So it was a great setup there.
Just for everybody's interest, 2 weeks from now, we've got a colleague down at Scripps with a medical perspective, although you covered the medical perspective very thoroughly already, but another counterpoint discussion of this condition for those who are interested.
I'd love to listen in on that, actually.
Oh, you're most welcome. You're welcome to listen in for the whole series. If you keep in touch with Dave Rosenstrike, he's an old friend of mine.
Yeah, we had, I worked closely with him. We had a great relationship. He's fantastic.
All right, well, thank you for a very instructive presentation. Unless there are any other questions, we'll let everybody get to work.
Thank you.
Bye-bye.
Bye-bye.